I guess the main thing I was asked to come and talk about was kind of my non-traditional HIM role. So I'll start off from the beginning. This is what Damon used to look like in the old days. This was 1982. I grew up in Watertown, New York, and applied and got accepted into Damon in the physical therapy program. After a couple of years struggling at that, I decided it was a time to change. So I went into the medical records administration program, and it turned out being exactly where I should be. So that was really fortunate. While I was at Damon, I was in class one day, and the teacher announced that the VA was looking for somebody part-time to come and just do clerical work. So I gave them a call, and I went over and interviewed, and they gave me the job. So I started working part-time there, which was a real blessing, especially doing that while I was still in school. I learned a ton doing that. In 1986, while a friend of mine and I were out celebrating making the Dean's List, we drove into a tree, and I ended up breaking my neck and everything in my face and my hands. So that put me back about a year in school. That's why I've got a couple more years on here, 6 years instead of 4 to graduate because of that. That set me back for a while. But I did eventually graduate in 1988. Sat for the RHIA exam and passed that, and started working full-time at the VA at that point. They accepted me into a full-time position. When I was doing the part-time position there, again, that was back in the days when everything was paper. So my first job was just going through operation reports and sorting them by what they called then terminal digit order, because all of our records were filed by the last 4 numbers of the veteran's Social Security number. So I would sort those reports so they would be in order. So whoever did the job of putting those in the medical records, they're ready to go in order. So again, that was a good first place to start. When I started working there full time, I started the coders at that time. Again, everything was paper, and what they would do is they had these data abstraction sheets where they would write down not only all of the diagnosis and procedure codes, but all of the administrative data that went with that patient's stay, their admission date, what kind of admission it was, if they were service connected, non-service connected, all of this administrative data. And they would write that on these big sheets, these data abstraction sheets, which I would then take up to the teletype people, and they would teletype that information in, and it would go off to the VA central office where all of that data was stored. And then I eventually started entering that information for them on the sheets. So I slowly kind of got into the coding part of the job at the VA by doing that work. Yep. Yeah. Now I'm up to the VA, and that still looks the same. So that's what I started out doing. About that time, I had the accident, so not only did I have to stop school for a while, I had to stop working at the VA for a while too. And after about a year, I was able to go back there. And then what I started doing was one of their first electronic files was the PTF file, which is the patient treatment file. And that was the data I was talking about before, where we would take all of the inpatient information and enter that previously on those abstraction forms, and they would teletype it. Now we were able to data entry it into the file directly. So that was my job. I was just taking all the cards that the coders had filled out and typing that into the file. And that's when I first started drinking coffee, because I would start that at 8 in the morning. By 10 o'clock, I'd be nodding off because it was just the same thing over and over and over. But it was a good introduction to coding, what the different kinds of data were, what the information meant, what if a patient was service connected and how that would affect what they were being treated for. But if they were being treated for a service connected condition, then the VA would pay for that care. So, and then eventually I started coding. And, they just started me off with the basic, easy cases, usually the alcohol and drug rehab stays or the basic cardiology stays. And started getting into the coding. The other thing that I did that I didn't like at the time, but was extremely useful, was doing all the dirty jobs. Someone always had to go up on the wards and bring all of the medical records down. And so we had 10 different floors. We didn't have patients on all 10, but probably about on 8 of the different floors we had patients. Yes?
How big was your HIM department?
I'm sorry?
How big was your HIM department?
At the time, we had probably about 7 to 8 coders, about 5 people that did like the data, the processing the records, and the file room was huge. The file room probably had 20 people. Yeah, it was huge. Yeah. So, but yeah, the dirty jobs, the one thing was going up on the wards and getting the records. And when a patient was discharged, the ward clerks would take all of the forms that they had, put it together into the patient's medical record. A lot of times their records would be that thick because they would come in so often. But then I would have to go up and try and find them. I'd go up on the ward that they were discharged from, and they were supposed to be in a certain location, but usually they weren't. So you had to go hunting all over the place trying to find these records. So that was kind of a pain. And then the big pain was we had this huge cart we had to use, and then we had to get that onto the elevator. And every time the elevator would come, it would be full. So you could sit there for 15, 20 minutes sometimes before you would get on the elevator. So, yeah, and there's like 10 of them, but they're packed all the time. So, yeah, that was one of the dirty jobs. Filing records, when they would get a huge backlog, they would ask us sometimes to file and sort forms and then file them. That was an undesirable job. And then any of those other things, I would just volunteer for because I wanted to get the experience. You get the full experience of what was involved with medical records in the department. And so that was really useful. One thing we started doing at that time that I think was one of the best things we ever did was concurrent coding, where we would go up on the wards as soon as somebody was admitted, and we'd start coding the record right at that point. We would enter the information. We would get a DRG, an initial DRG, and then we were invited to the discharge planning meetings, and we would go. And if the patient was at or past their allowable length of stay for the DRG, we would actually have to put a sticker on the form, and then the doctor, usually the doctor who would be at the discharge planning meeting, would have to address what their plan was to get that patient discharged. So that was the first time in the VA where they really started having to be accountable to getting patients out at a reasonable amount of time. Yes?
What year was
That was, let's see, that was around 1992. So that's when DRGs came along, and again, the VA would pay for the patients because we weren't billing third-party insurance yet at that point, but they were starting to get to the point where they had to rein in cost. There were some of the old-time docs that would keep patients 30 days for hypertension, or they came in with hypertension out of control, but they were an alcoholic, and they wanted to give them time to dry up before they discharge them. And it's just, they got to the point where, they couldn't do that anymore. So, but that whole process of going up and going to the discharge planning meetings, you just learn so much about that end of the patient actually being in the hospital and what was involved with that. So that was incredibly helpful. The other big thing that was helpful there, and a big complaint of the VA at the time and still at times, was our customer service. So we had mandatory customer service training. And it was just stuff you never even thought about before, just the basics of, treating people and treating patients. And what a big difference that made when everybody was trained and started providing that good customer service. And it just, the veterans really appreciated that. And then about 1995, I'd been there 9 years. The VA central office decided that since a lot of the patients that had been living in the Northeast were now moving to Florida and Arizona and places in the South, that they had to also realign resources to go where the patients were. So the Buffalo VA was going through what they called a reduction in force, and they were going to be reducing 200 positions. And I'd been in the department 10 years already, which was a fairly significant amount of time, but the problem was every time they hired a new coder, they hired them from somewhere else in the hospital and would bring them in and train them. So everybody had more years in than I did. So I knew that I was probably going to get caught if I stayed. So before that happened, I started looking for jobs in Western New York, in New York, on the East Coast, and at that time there was hardly anything. There were hardly any coding jobs. There were hardly any HIM jobs, especially in New York State. The only jobs that were available were traveling jobs, which I was interested in, but they were all, you were traveling either day to day or week to week. And so you would just be traveling all the time. And even though I was single at the time, that was more than I wanted to do. So out of nowhere, this job came along at the Salt Lake City VA. It was for a coding supervisor. It was a next grade up. I didn't want to move that far, but I didn't have much of a choice. So I interviewed and I got that job and moved to Salt Lake City. So that was in 1996. Yeah, I think I went over all of that. It's not the greatest picture of the hospital out there, but you can see the mountains in the back. It was a very, very beautiful place. So when I started at the Salt Lake City VA, I wasn't the coding supervisor at first. My job was ambulatory care data capture coordinator. This was soon after the VA started. They made the move to providing outpatient care for the veterans. Up to that point, it had been all inpatient care. And so they were shifting to outpatient care, and they were also shifting to beginning to bill for third-party insurance. So it was a real big shift in the VA with both of those programs. So the ambulatory data capture program was brand new, and the file that they created was brand new, and there were just all sorts of problems. I hadn't done any of this at all before I took the job out there. So when I went out there, I was just like, I was like lost, and nobody else at the VA there knew anything about it either. So a lot of it was just conference calls with the people in the VA that were running the program, and just trial and error. One of the big things with this is we had to design what we called encounter forms. I don't know what they would have called them in the private sector at that time, but they were basically the forms where when the provider would see the patient in a clinic, they would check off their diagnoses, check off their evaluation and management code and any procedures. And then that information would get entered into the computer. So it was all brand new. I was in charge of creating the forms. I was in charge of going out and training all of the providers, updating the forms every year when there were new ICD-9 and CPT codes. I would also evaluate what codes that clinic had been using over the year, and if there was a space for write-ins. So if the code wasn't on there, they could write it in and call our department. We'd give them the code. And I would take whatever codes they were using the most and then update the forms so those were on there. But that was, like I said, a lot of it was trial and error, especially creating the forms. I started off with it. Some of them were like 5 pages, and there were no way the providers were going to fill out a 5-page encounter form. So I had to learn to get those shrunk down to just the most important information. And going out and training people, I hadn't done any of that at the Buffalo VA. I hadn't had to go out and do presentations or anything, and it's not one of my best things. So that was extremely hard, but again, one of the best things I could have done to go out and do that. After about a year of that, the VA decided to have an ambulatory data capture conference in Kansas City, so I was allowed to go to that. And a lot of the problems that they were having at that time, all of the sites sent 3 people, so 150 sites, it was about 450 attendees, where we went, and a lot of the problems were expressed at that time, and a lot of the things were straightened out, so that was good. Another thing was our regions in the VA are called VISNs, Veterans Integrated Service Network, so they're basically a region. There's 22 different regions in the VA. We were in Region 19 in Utah, but that included all of the hospitals and clinics in Utah, Colorado, Montana, Wyoming, parts of Idaho, parts of Nevada. So we had 3 people from the VISN, and we went to all of the different facilities to evaluate everybody's ambulatory data capture program. So I was invited to do that. So again, another great experience, going to all of those hospitals and in all of those different states, and just the travel alone was just incredible, going through the Rocky Mountains, and you were out in the desert, and it was just really cool. And through that, I made some really good connections within the region, people that were in the central office for the region in Denver, which would come in handy down the road. And then we also started up an HIM committee for the region, where we would meet once or twice a year, and we would have conference calls and work on the different issues we had as far as HIM went. Kind of going back to the beginning of the job in Salt Lake, 2 days after I got there, my supervisor, who was the coding supervisor and the assistant medical records department director, announced her retirement. So it was just really good timing. There was no opportunity to move up at all at the Buffalo VA. All of the people, the coding supervisor, the HIM director, were all like 2 years older than I was, and they weren't going anywhere. So there was no opportunity to move up at all. And going out there, I'd moved up a grade, and then the supervisor retired, and I went up 2 more grades. And then after that, a couple more grades before I eventually left that job. It was just perfect timing. So with that, besides being the ambulatory data capture coordinator, I also became the coding supervisor and the assistant director of the department. And that was a really good experience. I had the director of the department was awesome, and then the director of the patient of the, what did we call it at the time? It was basically the business administration offices, which we were a part of. The director of that department was great too. So I learned a lot with that, and they gave me a lot of latitude. I was able to do a lot of stuff on my own where I saw there were needs, and to make improvements. And one of those areas was doing data analysis. I had learned how to do that at the Buffalo VA, doing coding studies and looking for, reviewing records of what the other coders had done, and finding where there were deficiencies. And I took that experience and I started doing it out there as well, and started with inpatient and outpatient coding. The main thing, looking for incorrect coding, but also looking for where complications and comorbidities may have been missed, opportunities to optimize coding. We also had reports where we could determine incomplete encounters, where the providers hadn't completed the encounter forms for their visits, especially for those that were billable. I mean, we were losing out on money if they didn't complete those encounter forms for cases we could bill. One of the biggest things I found was the Salt Lake VA at one time had been doing all of the heart transplants for the VA, and they had done hundreds of heart transplants. And once a year, the patients had to come back there and have a biopsy to make sure that the transplant was still good or if it was having problems. And no one had been coding or entering any of those cases into the system, and some of those, and many of them were billable. So once I entered that information and I did a report, and I went to the chief financial officer, and he saw what was missing and what I was able to find. They encouraged me to do more of that kind of stuff. It actually made a big difference in the collections that we had. And then for our other patients who didn't have billable insurance, the VA had their own kind of calculation on how VA central office would reimburse the different sites for their care, and it was called VERA. It was this really complex formula, and it went by basic patients to medium patients, then the very complex cases. Bless you. And that was another area where I was able to find where we had patients that would fit into that complex care category that weren't getting there because certain things were being missed, like complications and comorbidities. So just stuff that I was really interested in doing and ended up benefiting the hospital. The other great thing out there was, besides being invited to a lot of these committees, I was able to go out and join ones on my own without being asked. Medical Record Committee was a big one, and that was a really important one because we had a physician who was the director of the Medical Record Committee that was also an informaticist. And it was kind of the first time I'd met somebody that was into health informatics. And we actually devised a medical record review program with our charts where we would review charts initially based off of the Joint Commission requirements. And we would identify charts ahead of time that met all of the criteria. So when we had our Joint Commission visit, we pulled all of those records. And so when those reviewers would review the records, everything was there, it was met. And the physician presented to them on what our process was. And when they met with our medical center director, they told them that we had probably the best process they had seen. And it was just having that physician with his experience and the rest of us working together and coming up with something new that was really cool. But I was a member of all of these other committees too, and the main thing I wanted to put that there was just the experience I gained. It wasn't stuff that a coding supervisor necessarily would have been on all of these different committees, but it was either through invitation or through just something I was interested in, and they would accept me. So this period at the Salt Lake VA was 5 years, and I would say the favorite part of my career was that 5 years at the Salt Lake City VA.
How long were you at the Buffalo VA for?
I was Buffalo VA for 10 years, and then 5 at the VA in Salt Lake City. In the VA at that time, it had been in there for a while, but it was just starting to take off. The VA had a central office for an office of information, basically the people that did all of the programming and the developers, all of the people that were creating the electronic files and packages for the VA and the early developers of the electronic health record in the VA. And the VA had one of the earliest electronic health records in the United States. When I was on those VISN 19 committees, I'd met a couple of people from Denver who, the one lady ended up going to the Office of Information Field Office as the director. And they were looking for someone with an HIM background for their health data repository project. And I got a call from her, and she recruited me for the job. And the great thing it was, a GS-13. That's a grade system in the VA. It's a fairly high grade, and if you're in the hospital, if you're a GS-13, you're going to be either the director of the Health Information Management Department or a higher department, and you would be supervising a lot of people. But this position in the Office of Information, I didn't have to supervise anybody, so that was kind of the selling point. And it was something where I would be using my HIM background. So, and the chairman of our medical record committee, he was also working up there. So he also gave me a recommendation too. So it kind of all worked out really well. So what I started out doing there was the VA had started a national health data repository. What they wanted to do was we had over 150 different VAs and over 1,000 community clinics. What they wanted to do was have all of the clinical data for all the patients in one repository. So any reports or anything that they needed, or all of the data needed for the electronic health record, would go to that repository, and it would have all of the patient's information no matter where they had been seen in the VA. And we have a fair number of veterans that are seen in at least 2 VAs, especially up here, the guys that go down to Florida. They're seen at least at 2 VAs. Some of these guys have been seen at 20 VAs because they travel a lot or they just move around the country. So a lot of our veterans had been seen in at least 2 VAs, and the goal was to have all that information available for the clinicians at the point of care. So it was a lofty goal. Again, my job was going to be the data content lead. So what my job basically was, working with clinical people, was go through all of the VA's electronic files and identify all the files that contained clinical data. And then we had to get down to all of the discrete data elements for that data. Very, very detailed information, you know. So like for coding, you know, their diagnostic codes, their procedure codes, anything that was clinical data in an electronic file, we had to identify. And then that was the data that was going to have to be built into the repository. So that was my initial job. And that was really interesting because I went through all of the VA's files. They had about 2,000 electronic files at the time, and went through each one and identified which ones had clinical data, and then went through and identified all the fields that actually contained clinical data. The next part of that was a lot of that data had to be mapped to vocabularies or terminologies. You know, the coding data was already mapped to ICD-9 or CPT, but we had to take the pharmacy data and the lab data, and they had different terminologies that data had to be mapped to. So I had to work with 3M at the time. 3M was located in Salt Lake City, and they were our vendor for doing the mapping work. But they had to have somebody on the VA side to explain to them the VA data in order for them to map the data. So that project went on for a couple of years. Another big thing I did at the time is we had a change control board. Any of these projects, these IT projects, have a change control board. And you'll have basically your initial requirements. And if you want to add anything to that project, if you wanted to add a field or if you wanted to add a file, you couldn't just do it. It had to go to a formal process and a change control process, because anything that you add would affect the schedule and the amount of money it would cost to develop that project. And so it had to go through a formal process in order to do that. So that was another area where I learned a lot about that side of IT projects. This was a scary job to take on. The first day I went there, my first meeting, the people, and the project was just starting, so there were only about 3 people that were on the project, which eventually grew to about 100 people. I had a meeting and they talked about things for about 2 hours, and they were throwing all of these acronyms around. And the one I recognized was CPT, and I raised my hand and I said, does CPT mean current procedural terminology? And they said, oh no, it means this. And I was scared to death. I was like, I have no idea what I'm doing or what I'm going to be doing. I was really thinking about turning it down and going back to my old job. And it took a good 6 months at least to really start getting, feeling semi-comfortable with working on an IT project. It was really, really different. So, besides doing the HDR work, I was getting into some other different things too. One of the things when you're on an IT project is the first thing you have to do is you have to gather your requirements. So I was doing some of that work as a business requirements analyst. Any of the projects, you have to work with your business owners and identify what the business requirements are going to be. The other thing I started getting into was it was called a standards architect. An architect is somebody in an IT project kind of identifies and designs what they call the models will be, the model of information. And I wouldn't consider myself an architect, but I started getting into standards standards work with different standards organizations. Anybody heard of HL7? HL7 is a big standards development organization that develops standards in a lot of healthcare areas. So that was, I started attending HL7 meetings in their committees. And initially they had a medical records committee that I was involved with. That kind of disbanded as they got more into electronic health records. I got into a structured documents committee that was dealing with consolidated clinical document architecture standard, and into these different committees that were working on different things on standards, which our involvement was to attend those meetings, review their standards, and if their standards had gaps for requirements that the VA had, we would take our VA requirements to them and have them build those into their standards. So that was kind of my role, was to represent the VA. I'd review their standards and identify those gaps and then work to get the VA's requirements into those standards. So I had started doing that at that time, and that's basically what I'm doing now. While I was still out there in Salt Lake, I took a part-time job at a community hospital. We were needing a little more money. We were starting to have, I was married at that point, and we were starting to have children. And so I took on a job at St. Mark's Hospital, which was a 5-minute walk from my house. They were looking for a part-time coder. So I took that on. It was inpatient coding. It was 10 hours a week. It was just enough money to make a little extra money. But the other great thing about it was a private sector hospital. I'd never worked in the private sector before. So that was a really good experience, coding in the private sector, and not just doing male veterans. I was doing females. We were doing newborns, and that was a really good experience. I did that for a year, and I really enjoyed that. About that time, we were looking, our family was looking to get back to the East Coast, getting closer. My parents were still in Watertown, and they were in their 80s. They were getting older, and I wanted to get closer to home. The VA had a field office in Albany, so we were looking to try and get back to Albany, and I would just transfer from Salt Lake to the Albany field office and continue in my work there. So I applied for a couple of different positions. One was as a business requirements analyst for that office, and that's where I thought I would actually get a job. And then there was another opening for a standards architect, and I applied for that just, I had done some of the work. I had been at HL7 meetings, and that one I was just kind of, well, let's just see what happens. Well, that was the one I actually got a call about and got interviewed, and since I was the only applicant and I had experience, I got the job. And I asked, can I move back to New York? They said, yeah, you can work from home. So that's how I ended up coming back to Buffalo. I grew up in Watertown, but my years in Buffalo I really liked. I didn't want to leave Buffalo when I had to move to Salt Lake City. I really loved it here. So my wife had been here a few times, and she liked it too, so we moved back here. And that was in 2008, so we've been back 9 years already. It just seems like a year or two. We love being back. I love being back here. And I work from home. I'm doing standards analysis work, like I was talking about, taking VA requirements, working with not only HL7, another standards development organization is Clinical Loink. They do a lot. Well, there's Lab Loink. They have used Loink for a lot of lab data, lab test data and results. But Clinical Loink is, they use that classification for a whole variety of uses. One is standardized names for document titles, ventilator settings. They've found that they can use it for all different purposes in electronic health records that didn't have a way to classify before. After I was in that position for a couple of years, the director of the office asked me to start analyzing the meaningful use in EHR certification mandate that came out about that time. At that time, the VA wasn't required to meet meaningful use because it was a Medicare program and we don't bill Medicare. But she still wanted to see how it might pertain to the VA. So I had to get into the regulation and just go through and read it all and pull out all of the relevant information. And a lot of the EHR certification was important because it was all different kinds of data and standards required in order to get certified for meaningful use. So I did all of that analysis. It took a long time, and I presented that. And once they had the data, they decided that the VA was going to pursue just the EHR certification portion of meaningful use. We wanted to be able to say our electronic health record was certified just like everybody else. So that was about a 3 or 4 year effort. It kept changing because the EHR certification would change every 2 years or so. They would have new requirements, so you had to go through and update all of that. And the VA kept stopping and starting on if they were going to do it or not. We finally compiled a project team of about 100 people, and we were all set to tackle it. And leadership in the VA, and especially in our area, changes about every 2 years. And every new leader that comes in has their pet projects. Well, the new person that came in decided, no, we're not doing meaningful use anymore. So all of that work we had done just stalled. That's one unfortunate thing in IT in the VA is so much doesn't ever get finished. And that's a real frustrating part of working in this part of the VA. So I'm back to standards work again doing standards requirements for EHR projects, getting involved in the different HL7 work groups. A new group that's being formed is called the Healthcare Services Platform Consortium. And they're a group that actually wants to kind of fast track standards development and speed up the process because the HL7 process is extremely slow. And so this group wants to speed up the process, get enough people involved, and get enough support to really start pushing it forward. And a lot of what I'm doing now is we work with contractors all the time. We bring in contractors to do a lot of the very detailed and the very technical work. And so I've been involved a lot in evaluating contracts and contract offers and also writing up task orders for contractors to bid on. So that's been a lot of what I've been doing lately is that kind of work. So the other thing along the way, and this is something I would encourage all of you guys to do, either now or when you get out into the field, is to consider volunteering in HIM. My experience with it was kind of interesting. I went to a presentation in Utah by UHEMA, their state association, and their president was talking about something about the VA, and she was just totally wrong, totally incorrect. So I talked to her about it, and I was a little upset. And she said, well, why don't you volunteer for the board? And I thought about it, and so I did, and next thing you know, I became the secretary, and I started doing presentations and really got involved with their state association out there. Their state association is probably about the size of our Western New York Association, so it wasn't that big, but they did a lot of good work. And so I had that experience, and then I started getting into AHIMA committees and work groups there too. I've probably been on 10 different work groups or committees at AHIMA in different areas. And another great way to make connections and to learn stuff that you're not learning in your current job, but connections especially. I've been a textbook author for one of the, AHIMA's HIM textbooks, chapter on vocabularies and terminologies for 2 different versions. That was an interesting project, and it wasn't that hard, really. So that was good. And the main thing there was the connections I made. A lot of really good connections through AHIMA over the years. Since I've been back with the local association, I started out as one of the committee chairs, I believe, and ended up eventually being the president of the local association. Again, it wasn't that bad. It wasn't that hard. The only kind of difficult thing was we were hosting the state convention that year, so that entailed some extra work getting prepared for the state convention. And then I've been involved with the state association here as well as a local volunteer and various things, and that's a great group of people. Both the local and the state are really good organizations, and I would recommend you guys get involved with those. You can be just a small task or helping with one little project or something, and the experience you gain and the people that you meet, you never know how that's going to help you in your career in the future. The connections I've made along the way have really helped me. Then finally, this is just information about the VA if you're interested at all. There's a link here for the National HIM program. You can go in there and they've got information on everything about the HIM program in the VA. And there's a ton of stuff. The central office has about maybe 8 to 10 HIM professionals that all kind of lead a different major program for HIM in the whole system. So there's tons of information on there. It's very interesting. And then if anybody's interested in a VA job, the place you would go is this VA jobs, va.gov jobs site, and it shows the jobs locally and throughout the whole system. So in case you're interested, it's a good place to work. The VA, the pay's good, the benefits are excellent. I've been there 31 years now, so I get a lot of leave, and it's a really good place to work. It's it gets a bad rap every once in a while when these crises come up, and these the thing with the scheduling thing in Phoenix a couple years ago. But as soon as those things are identified, the problems are tackled, and they try to correct them as soon as possible. So it's a good place to work. That's it. Any questions? Yes?
Are people getting worried about, because they just passed that thing to the VA where veterans can go sue the provider of their choice?
Mm-hmm.
Is that scaring people? Like, is that going to screw up any of the records, or?
No, well, that's a big part of what we're doing now is, again, making sure that the information is interoperable, that any information that we have at the VA, if they're going to see a private doctor, as soon as they go into the record, they've got all of the data there.
Okay, so it's going to be connected?
Yep.
Okay.
It's currently connected to a certain extent, and we're working on getting everything interoperable. That's a big part of what our office is doing. And that's a lot of, standardizing the data. The data has to be standardized as much as possible before it can be interoperable. But a lot of it is now. We have a couple of projects where they're working on that.
Did you guys know about it before the rest of us?
About what?
The changing the provider thing, so were you guys able to get a head start on it?
Yeah.
Okay.
Yeah. Yes?
So do you know anything about the combining the records from active duty that system, are they working on that?
Yeah, same thing. They're working on getting the DoD data and the VA data all accessible from the same point. There's different projects. There's a project, working on that. There's a project working on that. There's different projects, and eventually the work that each of them are doing will all come together to make the whole thing work for everybody, wherever a VA veteran's going to be seen. If it's when it is records from the military service, or if he's seeing a private doctor, eventually it's all going to be all there. It's just, it's huge. It's a huge effort, and it's expensive, and it takes time. But in each different area, there's work going on. So, yep.
With more veterans, statistically, there's more veterans nowadays.
Mm-hmm.
Is that creating more jobs?
I don't know if it's creating more jobs. It's definitely retaining current jobs.
But that's good.
But yeah, I mean, the last major group of veterans we had were the Vietnam era veterans, and they were starting to get older. And when I first started in the VA, it was all the World War II veterans, and there were tons of them. And now a lot of them are gone. So the VA was working on downsizing because of all of those veterans being gone. And then the conflicts we've had in the last 10, 15 years has brought the numbers back up. Yeah. So, yes.
So within our program, we use Near Perfect, which is modeled after the VA system.
Mm-hmm.
And there was talks about switching to a different platform within the VA.
Yeah, and that's probably going to happen. We're probably going to acquire a commercial EHR system. It's what the Department of Defense has done it, and usually whatever the Department of Defense does, we have to do too. They have a lot more influence and clout than we do. So we probably are going to acquire one. The last I heard was Cerner. But there will still be, still the work that we're doing with the standards and stuff is still going to be required. No matter if we acquire that system, we're still going to have to integrate the VA data into the commercial system.
Which is going to be a huge undertaking.
Yeah.
In terms of cost too. Why
Oh,
are they
the-
looking to move away from Near Perfect to?
It's taking too long to get the VA Vista system up to the same level as some of the commercial systems are. The commercial systems, because a lot of them had to meet the meaningful use requirements, VA system isn't there yet, and we want to be on the same level as everybody else. So yeah, it's going to be, I can't even imagine how much it's going to cost, and then how long it's going to take to integrate into the system. Yeah. We're currently working with a project that they're concerned that their project's going to go away, but a lot of what they're doing is kind of building the foundation for the IT system, and now they're thinking, well, we won't be going away. It'll change a bit, but what we have to do will continue whether we acquire a new system or not. So.
What is the timetable for that when they decide or when?
Well, we're still waiting for the secretary to officially announce it, which I would say will probably happen in the next couple of months at most.
And then just my other question, regarding what just happened to ECMC and their computer system, how is the VA looking to what occurred there to make sure that, because that would be, ECMC is one hospital, I would think if they do it to the VA hospital, that's a whole network.
Yeah,
So,
I know, and it's scary because if it affected the VA, it would be such a huge impact. They're constantly doing security analysis and checking the systems and stuff, and it's good what they're doing. I can't say that kind of problem like at ECMC wouldn't occur. I mean, people are getting so creative now with what they're doing. It could possibly happen. It wouldn't be good if it did, but they do a lot of surveillance. I mean, there's hundreds of people that's all they do for the VA, is constantly doing surveillance and updating the system and protecting it. But it's still vulnerable like any other one is. Any other questions? All right, thank you. I guess the main thing I was asked to come and talk to. I was kind of my non-traditional HIM role. So I'll start off from the beginning.